no one knows me. And feel free to ask questions in the chat. There's not that much to say about my career, but I thought I should just start off with a bit of a spiel because because you guys are a bit, more junior than I am. So I trained at Western Hospital in Melbourne. I always wanted to do infectious diseases actually, and did my research project in medical school in infectious diseases. And someone said it's a good idea at Western, there's a rotation to the Royal Melbourne Hospital for the bone marrow transplant unit. So someone said, it's a good idea to try that. There's a lot of good infectious diseases. And that's when I became interested in haematology. So I've done 2 clinical years as a haematology registrar at Peter Mac Royal Melbourne, and the second year at Eastern Health in Melbourne, which is another suburban hospital. And this year's my first year as a lab trainee at Northern Hospital. I'm happy to answer questions at the end about any of this, but all I'd say is that there's many things you can learn from any hospital. So definitely don't feel like if you're not working at, the biggest hospital in the state that you can't learn something about haematology. So all of these cases are real cases I've seen over the last 2 years. They're probably the most interesting thing about haematology, I think, because they're life-threatening, hence they're called emergencies. But they're things that probably the haematologist is the only one who knows how to manage in the hospital. And all of them have very particular management strategies that need to be implemented pretty quickly. And all of them are life-saving. So all of the diseases I'm talking about today are potentially curable and treatable. You definitely don't know how to manage these. And the other thing I'd say is, as a junior staff member, if you call a haematology registrar or a haematologist and think any one of these things is going on, no one's going to be angry at calling you, because this is, what we worry about too. All right, so case number 1. This happened during COVID 2 years ago. So you get a call from an emergency at 4 a.m. All these emergencies tend to happen in the middle of the night. 20-year-old female who's lethargic, looks unwell and is febrile. The automated counts you get from the machine are on the right. There's no differential provided. So sometimes what happens in this situation, you're probably used to seeing, a differential where you get neutrophils, monocytes, lymphocytes. Depending on the analyzer, if the analyzer is not confident breaking down what the white cells might be, it sometimes just errors out like this, and you'll just get a number. You won't get a differential of what they might be. So this kind of thing will get flagged in the lab. So it's not something in the emergency department that you need to be thinking too much about. I mean, although obviously even anyone can recognize that this is highly abnormal, but there's no one in the lab, unfortunately, to look down the microscope and see what these cells are. The lab registrar will have to drive in to have a look at the film, but they live an hour away, so it might take a while. So does anyone want to put something in the chat what they're worried about? Yep, they're clearly anemic, so hemoglobin of 50. Yep, infection's a good point. They are febrile. Their white cell count's pretty high. Leukemia, yep. Could it be a chronic leukemia, or do you think it's an acute leukemia? You can't tell, but I mean, I think the fact that the blood counts are very low and there's no preceding history, you have to presume that this might be an acute leukemia. So likely acute given age. That's true, although you can get young people with CML. It does happen. You can get pediatric AML. Bleeding anemia, leukemia. Yep, sure. All right. What have I got next? So high white cell count, is it leukemia? So the things that we think about with high white cell count is, firstly, is leukostasis. So leukostasis is a syndrome where essentially, because of the high white cell count, there's sluggishness of flow of the blood. The classical symptoms are headaches, visual blurring. This tends to happen more with AML than ALL because the blasts are quite large and sticky compared to ALL. Tumour lysis syndrome, something we worry about with such a high white cell count. DIC is something to think about. Could this be APML? You know, you can get DIC even if it's not APML. The other thing to think about is febrile neutropenia. And you might think, you know, the white cell count's so high, how can this be febrile neutropenia? But if they're all blasts, you're not going to have any functional neutrophils, and this could be febrile neutropenia as well. So someone's come in and had a look at the film. You know, you don't need to know how to interpret films, and this isn't actually the film. I couldn't find the film, but they've confirmed that the majority of the cells are blasts. They're quite small, the high nuclear cytoplasmic ratio, so that means there's not a lot of cytoplasm, and prominent nucleoli, suggestive of acute leukemia. And it can be quite difficult just on morphology alone to figure out whether this is myeloid or lymphoid. Sometimes you get a clue, but there's really only one way of finding out. So what other things are people interested in? I'll probably just put it straight up. Okay, so this is the differential you get on the left after someone's done a manual differential. So you have to look under the microscope, and each time you see a blast, you press a certain button and you get to 100 cells, and eventually you get this manual differential. The machine won't do that for you. And the biochemistry is on the right. Now, does anyone want to interpret the biochemistry and say what they think they're worried about?
Is this, I'm worried, this is Catherine speaking, I'm worried about tumor lysis syndrome, potentially.
Good, and what makes you worried about that?
Well, the kidney function is very off, yep. And given the serum creatinine and the EGFR, and I'm really worried also because you've got a high urea, and also when the cells lyse, you get a high potassium. So that's kind of my first thought. I haven't looked at the rest.
It's okay. So
and
the
high
things
urate.
Yeah, exactly. So the things we look at are urate being high, but that can be high just in chronic kidney disease. The LDH of 1400 suggests this is a highly proliferative disorder with lots of cell turnover. And you can see in this situation that even without treatment, this patient's got significant renal impairment. And that's something some people don't appreciate, is that, you know, in a situation where you've got such high blast count, regardless of you giving chemotherapy or not, there are cells that are dying and breaking down all the time. So this is what we call spontaneous tumor lysis syndrome. The thing we're worried about the most in this situation is probably the potassium. You can see that's already very high. And creatinine doesn't kill you, but it's a sign that there's quite advanced renal disease at baseline here. So next. Now, does anyone want to venture a guess at what happened between time point A on the left and time point B on the right? So the white cell count's gone from 640 to 550. You can see on the biochemistry on the right that the creatinine hasn't changed too much, but quite significantly, the potassium's gone up very dramatically from 5.6 to 8.9 to over 10. The phosphate's gone up, which is another marker of tumor lysis syndrome. The urate's relatively stable. I can't remember actually whether there was any urate lowering therapy given in this situation, but it presumably was. So what happened actually was the patient had a dose of steroids, which I think the hematology registrar advised because we thought it was lymphoid leukemia. But as you probably may or may not know, for lymphoid malignancies, so lymphomas, lymphoid leukemias, steroids are highly effective treatment. So, you know, in this situation, if you give 10 days of prednisolone, you can put the patient into remission. So a single dose of prednisolone is enough to precipitate quite profound tumor lysis syndrome in this patient. And again, the electrolyte abnormalities are hyperkalemia, hypocalcemia, hyperphosphatemia, and hyperuricemia. So tumor lysis syndrome is an oncologic emergency, and there's massive tumor cell lysis and release of electrolytes and nucleic acids into the system. So I talked about the biochemical features there, but the things that make us worry that the patient's going to have severe TLS can be related to the disease, the treatment, and the patient factors. So this is a young patient who doesn't have any pre-existing CKD, but you can imagine how difficult it might be to treat tumor lysis syndrome in a patient who's 80 with severe heart failure and pre-existing renal impairment. The diseases that are classically associated with tumor lysis syndrome are things like acute lymphoblastic leukemia and Burkitt's lymphoma, because they've got a high cell turnover and the treatment we give, steroids and chemotherapy, is rapidly effective. So how do we manage it? Firstly, you have to recognize that it's the patient's at high risk of tumor lysis syndrome, and what we do then is monitor the blood test very frequently. So, 4 times a day blood tests. We consider changing the initial chemotherapy. So for example, we might give a lead-in of steroids or split the dosing of chemotherapy to not overwhelm everything at once. We provide vigorous intravenous hydration, including diuretics to try to maintain euvolemia. Urate lowering therapy is important because high urate precipitates in the urine and causes a crystal nephropathy, which then becomes a vicious circle. So more damage to the kidneys and worsening of the situation. So allopurinol, it can be good for prophylaxis, but for really high-grade tumor lysis like this, you need resburicase, which is a recombinant uric acid, urate oxidase, which breaks down uric acid to degradation products. The main thing we worry about is potassium, and that's the thing that is going to kill your patient and you're going to need to do something about. And dialysis is sometimes unavoidable, unfortunately. So what happened in this patient? This isn't from our patient because it's got a language I don't understand, but in this situation, the patient required urgent potassium lowering therapy, went to ICU and had urgent hemodialysis. This isn't classical tumor lysis treatment, but in this situation, given how high the white cell count was, we opted to do leukapheresis, which is an apheresis procedure where the buffy coat is removed and discarded. So you'll see on the right, the bottom is a normal-ish sample where you have your plasma, your buffy coat, which is platelets and white blood cells, and your red cells at the bottom. And the patient, may very well be this patient with a very high white cell count. There's a lot of white cells and you just remove them and discard them. In this situation, we opted not to do a bone marrow biopsy because the answer's there in the peripheral blood, and indeed it was the acute lymphoblastic leukemia. The patient started on pre-phase steroids and went on to have hyper-CVAD chemotherapy. Any questions about this case? Okay, I'll move on to the next case then. So this is emergency number 2. This is a patient that had last year at Eastern Hospital. So 50-year-old man who's day 6 of a Beam autologous stem cell transplant. So what that refers to, in case you don't know, is Beam is the conditioning regime. So day 0 is the day at which stem cells are infused, and in the preceding 5 days, the patient has conditioning chemotherapy that exerts an anti-lymphoma effect. This patient had follicular lymphoma, I think. So B stands for BCNU or carmustine, E stands for etoposide, A stands for Ara-C, M stands for melphalan. So 4 very potent cytotoxic chemotherapy agents. So it's day 6. Morning ward round, feeling well. Most of the patients feel quite well at this stage. 7 p.m. he tells his nurse he feels a bit cold, and then he starts rigoring at 7:30 p.m. What do you worry about? Yeah, this isn't very complicated, this one. I guess the nuance is until you work on a transplant service, you don't really get a sense of what the counts are likely to do at this stage. But you ask anyone who does autologous transplant and they will tell you day 5 and 6 of beam or any really autologous stem cell transplant is when the counts are low. And this is what the counts might look like. So white cells are low in this situation. They haven't even given a neutrophil count because there's no neutrophils. So febrile neutropenia is probably one of the heme emergencies that you guys may be more familiar with. So obviously fever might be the only sign of severe life-threatening infection in this situation. It's the most common oncologic emergency and it's the bread and butter of a hematology registrar. The main risk is overwhelming gram-negative septic shock. Sure, patients can die of gram-positive organisms, fungal organisms, but the rapidly deteriorating patient who goes into fulminant septic shock is likely to have gram-negative sepsis. The general principles are that you take blood cultures and urgently give broad-spectrum antibiotics. Don't waste time, go and review the patient, examine them. You tell the nurses, go and get the tazocin. And then while they're getting the tazocin and infusing it, that's when you examine the patient and think about what might be going on and think about the source. The source is not often that important, to be honest. I mean, it is, you have to think about it, but it's often just low-grade gastrointestinal translocation because of the neutropenia and the lack of a functional gastrointestinal barrier. I wrote there consider, I think I meant consider line. Line sepsis does happen. It is something you have to think about because that is something you can potentially treat, taking out the line. I've written there febrile neutropenia versus febrile neutropenia. What I mean by that is that if you work on a hematology ward, you'll probably see 20 patients with febrile neutropenia. And after a while, you'll think, this isn't so bad. Febrile neutropenia, you know, you just give them some antibiotics and they're okay. But 1 out of every how many patients, they get catastrophic sepsis. So you have to treat it with respect. And there's a reason why we consider it emergency is that, you know, this is the reason why patients who are having an autologous stem cell transplant or AML induction do die. They die of infections, they die of febrile neutropenia. And depending on where you work, if you work at a large center, you know, your major transplant centers, the nurses will do all this without you asking. They have protocols where they don't even speak to you. They just put the antibiotics in and then they ask the medical officer to review once that's all done. You know, if you're in a country ED and these patients come in, or if you're in ED full stop, or if you're in a smaller hematology unit that maybe isn't as well set up, sometimes things won't be available. You might get told, oh, the tazocin, you know, we have to go to a different ward. We have to send to pharmacy. Oh, there's no IV access. If things aren't happening, you have to sort it out yourself. I've walked different wards, grabbed the tazocin, brought it back. You know, if you can't get IV access, call ICU. If they don't come, call a med call. This is a medical emergency. The other thing to think about is the order of antibiotics. So, for example, sometimes people use tazocin and vancomycin, which is a very, you know, reasonable option, especially if you're worried about line sepsis. What some people don't appreciate is that a big dose of vancomycin can take up to 3 hours to infuse. So if the nurses aren't experienced and you chart tazocin and vancomycin and they start the vancomycin first, you might be waiting 3 hours until your tazocin goes in. When, as I said, tazocin, well, I didn't say this, but gram-negative septic shock is the thing that's probably going to kill your patient fastest. So the tazocin is actually the most important thing to get in there first. The other things to know about are what your local hospital's antibiotic policies are. Some hospitals may have particularly high rates of multi-resistant gram-negative infection and suggest other agents such as aminoglycosides for shocked patients. So what happened in this patient? The other thing to say is that in these patients, if they start rigoring, they're going to have a fever soon. So this is a transplant unit. So they have nurse-initiated sepsis protocols, and within 10 minutes, the tazocin had gone in. Patient subsequently became febrile and had a MET call for hypotension. He had persistent hypotension despite fluid resuscitation. We added some gentamicin, which you do in shock. Added some vancomycin, although there was no real signs of any line infection, and changed his tazocin to meropenem. He went to ICU requiring a central line and vasopressors to support his blood pressure. And sometimes in this situation, ICU asks, what are you guys really doing? This guy's pretty sick. Do you really want us to intubate him and put him on dialysis? And this is a situation where you kind of have to understand the big picture, and you have to tell ICU, this is a curable malignancy. We want you to do everything. It's not ICU's fault for asking this. They probably hear some unreasonable demands from us sometimes, but this is a situation where you really got to stick to your guns and say, no, we want you guys to help us. So what happened with this chap? He had progressive multi-organ failure. He got intubated, required dialysis for acute liver failure. He grew an E. coli, so gram-negative sepsis. Interestingly, well, not interestingly, you often see this, the E. coli is fully sensitive. So even though we throw gentamicin, change the tazocin to meropenem, it's often not a lack of antimicrobial coverage. It's often just that these are very virulent organisms and the patient has no immune system. He engrafted on day 12 of transplant, had a very good renal recovery, ceased his dialysis later in the admission, got discharged home on day 20. Any questions?
I have a question, Matt. It's Catherine here.
Go for it.
Did this patient get any oral antibiotics to take home?
That's a good question. I honestly can't remember. The practice depends a bit on who you work with. Generally, if the patient's culture positive, we would complete a kind of 10 to 14 day course. If the patient, especially with something fulminant like this, for simple febrile neutropenia though, where the patient doesn't culture anything and is well, we generally I just generally stop the antibiotics when they can't recover. And generally they'll just stop having fevers when we've got neutrophils, but there's a bit of variation in practice around that.
Oh, yes, that's on discharge. Sorry, I didn't specify. I meant with their stem cell transplant.
Oh, prophylaxis.
And their beam therapy. Yeah, did they get anything to take in case they developed
febrile neutropenia?
Sorry. That's okay, I didn't specify.
This beam transplants are inpatient transplants.
Okay.
So they stay inpatient for the whole situation.
Oh, right.
At some hospitals, they will do outpatient melphalan transplants for myeloma.
Yes.
And those patients will sometimes get given an emergency supply of Cipro or something to take in the event of fever. But those patients are very heavily selected for people who are very sensible, live very close to the hospital. Generally, if we get a bit nervous about them, like they start having a lot of diarrhea, we just bring them in, because autologous transplant, there's a reasonable chance you get febrile neutropenia.
Thank you.
With beam, it's about 100%, I would say. You can't avoid it, unfortunately. For febrile neutropenia, yes, you can use cefepime if they've got a non-threatening penicillin allergy. The thing to think about with cefepime is you don't have any anaerobic cover, so you would have to use some metronidazole as well, just to cover the anaerobic translocation. Fungal cover in febrile neutropenia, good question. It's a complex question. It depends a bit on the main risk for fungal infection is the duration of neutropenia. So for most autologous transplants, they're only neutropenic for around 5, 6, 7 days, which is generally not enough to cause fungal infection. For allogeneic transplant or AML induction, where the patients are sometimes neutropenic for 2-3 weeks, those patients will often have fungal prophylaxis. in general, patients don't develop overwhelming fungal infection. When you tend to consider fungal infection is the patient who has no neutrophils, has recurrent fevers, is completely culture negative after 2 or 3 days. Move on to the next case. Emergency number 3. So this is a 50-year-old man who presented with bruising confusion. The exam was he was unwell, bruising everywhere, had blood in his mouth and is confused. This is the FB you get on the right. Does anyone want to hazard a guess what we're worried about in this situation? Or good, DIC. Just as a bit of explanation, I didn't know this until I did lab this year. When you see a monocyte count this high, they're not monocytes. Well, they can be, but essentially the way an automated differential works is it looks at the forward scatter and side scatter of the cells. So the size and nuclear complexity, and blasts tend to be quite difficult to discriminate with monocytes because they're both large and have reasonably high nuclear complexity. So often blasts will sit in the monocyte gate and can come up like this. Alternatively, like the situation before, it might just error out and give you a white cell count and no differential. And on the back end in the lab, we'd get a flag to review the film. So someone has driven in to look at the film. You guys obviously don't need to know how to look at the film. This is just a low power view to show that there's a lot of white blood cells. And someone's called, well, the hematologist has had a look at the film and called the emergency department and said, this looks pretty bad. This looks like acute promyelocytic leukemia. So there are 2 variants of acute promyelocytic leukemia. There's a hypergranular variant, which is the typical variant, about 90%, which is a little bit more classical to look at under the microscope. This is the hypogranular variant, which is a little bit more difficult to recognize, but the real key is these bilobe nuclei. It's very difficult to take photos from the microscope, but you can kind of see that all of these white cells have two lobes nuclei that are kind of connected in the middle. Someone said they can see our rods, which is very good because I can't really see any from this position, but there were some. So what is the most important next investigation?
Bone marrow?
Coags. So what I'm worried about is coagulopathy. So these are his coags, and everyone's people have put out the suggestion that this might be DIC. You might look at these coags and think they're not too bad, which they're not really. The PT is a little bit prolonged. The APTT is normal. The fibrinogen's a little bit low. Certainly they can look a lot worse, but they can bleed a lot more than their coags suggest. And this patient's clearly got coagulopathy of some description. So he's coagulopathic, and probably more important clinically, he's got a phenotype that he's bleeding. He's bleeding everywhere. He's bleeding in his mouth. He's bleeding in his skin. He's confused. Does he have an intracranial bleed? Something that you should know as the hematology registrar is, where is the ATRA kept in your hospital? It's usually kept in the hematology ward, if not in one of the after hours cupboard. Some small hospitals that don't treat leukemia don't have ATRA. I've driven from one campus of a hospital to another to courier ATRA to a patient once. You should know where the ATRA is. Of course the nurses should know as well, but sometimes if it's a bad night, there might be a junior nurse in charge who doesn't know where the atria is, and that's a disaster. Should I wait for a bone marrow biopsy before starting chemotherapy? So short answer is for APML, or even if you think it could be APML, just give atra. It doesn't have any harm giving 1 or 2 doses of atra. We generally wait for the bone marrow to give the rest of the chemotherapy, although again, that's not a hard and fast rule. But if there is any suspicion of APML, and certainly if there's any coagulopathy, you give atra before you confirm. So APML is a rare subtype of AML. It's about 10% of AML, I think. It's not that rare. I've probably looked after a dozen cases of APML in the last 2.5 years. So it does happen. You will see one if you do any work as a hematology registrar. Not all of them have such high white cell counts and overt DIC, but you still have to treat it as though they have the potential to develop that. So there's a characteristic translocation between chromosome 15 and 17 that causes a fusion gene product of the PML and RARA gene. And essentially you get accumulation at the promyelocyte stage, which, as you know, is the step after myeloblast. The importance of APML is I've written the most curable hematologic malignancy. I'm not actually sure about that, but it's certainly the most curable form of acute leukemia. So you can see on the right, the overall survival from the APML4 trial, which is a trial run in the 2000s of the most current treatment, which is arsenic and atra. And the survival rate at 8 years is about 95%. But the people who do die early. The caveat to this is that, in clinical trials, you're always going to select for the less sick patients. And actually, I think this trial only selected low risk acute promyelocytic leukemia, but the principle still stands that in general, we think if you can get people through the induction for APML, their risk of relapse is very low and they've got a very good long-term survival. But there's a very high risk of early death, mainly due to coagulopathy. And it's been shown that administering atra early reduces the risk of progressive coagulopathy and dying from coagulopathy. So management, give atra early without waiting for confirmation. You have to aggressively treat the coagulopathy. So we aim for platelets over 50, FFP to normalize the INR, cryoprecipitate to try to get the fibrinogen over 1.5. You have to be very aggressive and monitor very closely. You're checking their bloods every 4 hours, 4 times a day. And as soon as it looks like they're dropping, you give them more product. You have to be aware of what stock you have in your hospital. Some hospitals only have 1 pool of platelets available. You might deplete their stores, or not so much with FFP and cryo because they're frozen products, but you have to thaw those products. So you have to be in communication with your blood bank. The treatment is dependent on the white cell count, but it's some combination of atra and arsenic. And then for patients with a high white cell count, an anthracycline chemotherapy is included as well to try to mitigate the risk of differentiation syndrome. Differentiation syndrome, I'm not going to talk too much about today, but essentially that's a situation where the atra reverses the differentiation block at the promyelocyte stage, and you get sudden differentiation through the myeloid lineage, and you get a sudden rise in the white cell count and a clinical situation where the patient develops fevers, hypoxia, pulmonary infiltrates. And this can be quite severe as well. I've seen a patient who was ready to go home one day develop an unusually late differentiation syndrome, and the next day they're in ICU, 100% oxygen, intubated, almost died. Usually we would still try to do a bone marrow biopsy, but in this situation, the patient might be too unstable, and you can do all your tests on the peripheral blood. You can do flow cytometry to look for the immunophenotype of the blasts. You can do cytogenetics in fish to look for the 15-17 translocation. And you can do molecular studies to look at the percentage PML RARA. What happened in this situation? The registrar, this is the one of the few situations where the registrar will come into hospital after hours, gave ATRA, was very aggressive blood product support. Unfortunately, the CT brain showed a large intracerebral hemorrhage, and the patient had to be intubated and transferred to a hospital with a neurosurgical department, which the hospital that this patient was being cared for didn't have. And I don't know what happened with the patient after this. APML was confirmed on the peripheral blood. It's worth saying that this patient is up against it. So the people who really struggle with APML are people with very high white blood cell count, because they're very high risk of developing progressive coagulopathy and very high risk of developing differentiation syndrome as well. And white cell count is really the one thing that stratifies you in APML into low or high risks of early death. How does APML lead to DIC? That's a very good question, which I'm not confident enough in the answer that I will explain to you here. Sorry to disappoint you. I will have to read about that now. On the other hand, if you do work in a hospital where, something to say is working in a small hospital, you can see these patients early in the year, and then later on in the year, you're seeing them in outpatients. And after the first cycle, which can be very, very difficult and challenging to get them through, they tend to fly after that. The treatment is not that toxic. People can get peripheral neuropathy from arsenic. It can be difficult in older patients, but it's a very prolonged treatment. They require, 6 months of daily arsenic, but it can be very rewarding to see these people in outpatients 6 months later who are doing very well. Even people who've had intracerebral bleeding can recover remarkably well, because they can be young people as well. Okay, I've got 2 more cases. This is emergency number 4. This was very recently. This is the triage notes. So 4 days, lightheaded, tremors, diarrhea. They're the OBS. The patient was seen by a resident, thought maybe stress related. And then they thought the patient had a psychogenic non-epileptic episode in ED. You won't be surprised that this patient did not actually have a psychogenic seizure. This is the FVE. Who wants to hazard a guess or just say what they might be worried about? That's fine that you have no idea. The good thing about a lot of these diseases is that if you're an emergency clinician, you often struggle to identify these things, which they have to know a lot, but the lab will often be able to make the diagnosis for you, especially in a city hospital where the blood film can be reviewed a few hours later. And hopefully the machines are set up in a way that even if you're working in a country hospital, it still should flag, and it should get transported down to Melbourne pretty quickly for someone to have a look at. So people have said thrombocytopenia, which the patient does have. It's not really a diagnosis, but they then correctly said TTP, which is a good thought. ITP, it could be ITP, and the hemoglobin could be low because they're bleeding, I guess. ITP is a diagnosis of exclusion though, and you have to think about other things first. HUS is a good thought as well because of diarrhea. The thrombocytopenia is a little bit, maybe more than what you'd expect for HUS, but it's certainly a good thought. This is the blood. This actually isn't the blood film from the patient. This is the blood film from a similar patient. And what I'll point out, so I don't think you can see my cursor, but there are some nucleated red blood cells, which just means the bone marrow is working very hard. You can see some of the bigger red blood cells, which are a bit maybe light purple. That's called polychromasia or reticulocytosis. So that's immature red blood cells. And you can see there's quite a lot of what we call fragments or schistocytes, so broken up red blood cells essentially. So this is the report. Yeah, red cell fragments are noted along with marked polychromasia. Features are concerning for microangiopathic hemolytic anemia, so MAHA, such as TTP-HUS, suggests hemolysis screen. Who wants to put forward what's in a hemolysis screen? Your consultant will often ask you to do this on general medicine, and they probably don't know how to interpret it a lot of the time. Good. So FBE you should have already done. So you expect the anemia, which we've seen, although you don't always have anemia in hemolysis. If it's compensated, it could just be a reticulocytosis. So the reticulocytes are high because the bone marrow is working hard to replace all those red blood cells that have been broken down. The LDH is high because of cellular turnover. Bilirubin is high, haptoglobin is suppressed, and strictly speaking, that's, I guess, the hemolysis screen. Most people would do a DAT as well at that stage, although a DAT really is only for determining what kind of hemolysis there is once you suspect hemolysis. But most people just do it all at once. In this situation, no one actually did a DAT because it was pretty obvious what the cause of the hemolysis was. So TTP is a life-threatening disorder due to a deficiency in Adam's TS13, which is a metalloprotease that cleaves large 1 Willebrand's factor multimers into smaller units. In adults, it's almost always due to an autoantibody against Adam's TS13. In children, you can get congenital deficiencies. And because there's no Adam's TS13, you get accumulation of these very high 1 Willebrand factor multimers, which lead to widespread microvascular thrombosis. These are the classic pentat of symptoms, although hopefully you don't see them because that's a very late sign if you have all of them. So what happened? Thankfully, this was about 5 o'clock on a Friday. So the lab consultant called the hematology registrar who had to go and see the patient and stay late. We sent an Adams TS13 level, which goes to Monash in Melbourne. So only a few reference labs do it, and it will generally take a couple of days to come back. You don't wait for the Adams TS13 level to come back before you start treatment. Patient had a VAS cath inserted and went to ICU for urgent plasma exchange with cryodeplete plasma. They started on 1 milligram per kilogram of methylprednisolone, and I actually never met the patient because I was in the lab, but the registrar said the patient looked 10 times better the next day. They had weekly rituximab. So the rituximab is added to steroids to try to eradicate that autoantibody that's causing the problem. And meanwhile, while that autoantibody is being eradicated, the patient continues on plasma exchange. And we generally look at the platelets and continue exchanging until the platelets have normalized. Any questions? Can be very rewarding to treat TTP. I saw a patient in the country once who had known TTP and presented with very classic symptoms that indicated a relapse, and it's in the country, so you can't just exchange someone. So they were due to be transferred down to Melbourne, and they died while they're waiting transfer. What you can do if you don't have access to plasma exchange in the acute setting is you can give FFP, because it does contain some Adams TS13, although it's not the ideal treatment. It's really a temporizing treatment. This is a last bonus emergency that you may or may not be as familiar with as the others. So 70-year-old lady with Philadelphia-like BALL who didn't respond very well to conventional chemo, didn't tolerate it very well, had persistent disease after 2 cycles. She was admitted to the ward to commence salvage with blinatumomab, and the infusion starts late. She had a MET call at midnight for fever and respiratory distress. What are you worried about? Well, what is blinatumomab? Good thought. It's not the technical term cytokine storm, but it explains it really well. CRS, good thought. So blinatumomab is a bispecific antibody. One of my professors used to call it the world's most expensive paperclip. So on one side you have CD19, which binds to B cells, and on one side you have CD3, which binds to T cells. And the idea is that for B cell malignancies, you bind the, let me start again. The bispecific T cell engager binds to the malignant B cells and brings them into close proximity with T cells. And that causes engagement and activation of the T cells to cause cytotoxic killing of the T cells. It's the only bispecific currently widely available. However, almost guaranteed by the time that you become hematology registrars, there will be others that we are using routinely. There's glofitamab for diffuse large B-cell lymphoma. There's teclistamab for multiple myeloma. There's BiTEs available in trials for solid organ malignancies. A lot of action in hematology is in bispecifics, not even to mention CAR T cells, which not obviously, CAR T cells have a very similar problem that you need to be aware of. So CRS is a syndrome where you have, as someone eloquently put it, cytokine storm, excessive supratherapeutic activation of cytokines and immune activation. It can be associated just with standard monoclonal antibodies, and some people call that cytokine storm. I tend to think of that more as just an infusion reaction. So we typically see that with things like rituximab or obinutuzumab, where the patients can get high fevers whilst the infusion is running in. But it's certainly classic with bispecific antibodies and CAR T cell therapy. The symptoms are fever, hypotension, circulatory collapse, hypoxia, respiratory distress, and it's quite serious. And there are very specific treatment algorithms, which probably because these drugs are not, I will say, if you work in a place where CAR T cells are being delivered, the nurses should be all over this and the registrars should be all over this. The thing to know is though, blinatumomab can be used at any hospital, and some of the smaller hospitals may not be as familiar with the management. So what happened in this situation was actually that I think there was a bit of delay in calling the registrar, because often in a MET call, you get a medical registrar. And when you see someone who's having chemotherapy with fever, you tend to think of infection, and they probably weren't as familiar with blinatumomab. So the patient had antibiotics, and there was a bit of faffing around before they called the hematology registrar. how do you manage cytokine release syndrome? Probably the most important thing is try to identify the patients so that everyone is aware when the infusion is happening and has access to the treatment algorithms. The people who are high risk are people with lots of disease on board, and often we try to debulk the disease before introducing medications like this, because if there's lots of disease, there's very high risk of cytokine release syndrome. Each drug kind of has its own protocol for how to manage the CRS, so you don't need to be familiar with exactly how to manage it. But what I'd say is call the senior person quickly, consider stopping the infusion if it's a continuous infusion. Some of these drugs are short infusions, some of them are prolonged infusions. The first step is always supportive care, oxygen, fluid resuscitation, Panadol, etc. Consider antibiotics. You know, these patients can still get an infection, but it shouldn't be the first thing on your mind. And then the two main treatment options are steroids and anti-cytokine directed therapy, so tocilizumab. So in bites, we tend to use more steroids and save the tocilizumab for severe manifestations, whereas in CAR T-cell therapy, we tend to reach for the tocilizumab first before going to the steroids. And the reason is because in CAR T-cells, we're a little bit more worried about giving steroids and causing and wasting the CAR T product, because steroids are very lympholytic, and you don't want to kill all the CAR T cells that you've just infused. Although the first priority is always treating what's in front of you, and if the patient's unwell enough, you just have to give them steroids. So what happened is the patient, she had some steroids. There's a lot of difficulty in the middle of the night trying to give tocilizumab. We weren't prepared where we gave this patient. It had to be made up after hours, but the patient was sitting up out of bed, eating breakfast a few hours later, and then had a re-challenge a week later without any cytokine release syndrome. The key in this situation was being familiar with cytokine release syndrome and how to manage it. This patient had struggled a lot in hospital and had a do not resuscitate because, you know, realistically, she wasn't doing very well. But in the middle of the night, there was probably some difficulty trying to convince ICU to provide the necessary supportive care, because they weren't familiar with the fact that cytokine release syndrome is very rapidly reversible and often just requires a few hours of supportive care whilst the cytokines are switched off. Any questions about that case? Otherwise, I think that's all I had. There are other emergencies, of course, that I didn't touch on, but I think those are kind of a good starting point. Some of the more interesting ones that if you spend any time as a hematology resident or registrar, you will encounter all of those. So, you know, I certainly don't expect you to be able to know all of those, but maybe just have some familiarity enough to maybe recognize it and recognize when you should be calling someone for help. But probably most importantly, I think they're probably these situations are the most fun aspects of hematology, because you really do have people who are very sick, who you're the only person in the hospital who can treat them properly. And sure, we do, you know, lean on our intensive care colleagues for help and our ID colleagues for help. But really, if you spent a couple of years as a hematology registrar, you're the best person in the hospital to manage febrile neutropenia, apart from your consultants, of course. Or, you know, you may be more familiar with your consultants managing cytokine release syndrome, because it's all very new, and, you know, we've often seen more as junior people than some of the senior consultants. So I think they're the most fun things to manage in hematology, but they can be the most difficult, but, you know, they're the most memorable as well. So happy to answer any further questions, or you're welcome to send me an email. And I hope you found it valuable.
Thanks, Matt. I think that was a very great talk. Lots of insightful